My name's Verity Ford. I'm Dual Diagnosis Practitioner at Recovery Near You in Wolverhampton. The QI project that I was part of was based on Mary Seacole ward inpatient unit on Ward 1. And the QI project was to ensure that all new admissions to the ward are screened for naloxone. So historical and current opiate use is identified, then naloxone is to be offered on discharge from inpatient unit. So prior to my move over to Wolverhampton team, I was the compass worker on Ward 1 and kind of in discussions around admissions and drug screening for admissions. The idea around naloxone had been discussed at some of our compass meetings about kind of its use on inpatient wards and whether we should be discharging patients with naloxone. It was then following an SI that had kind of been discussed at clinical governance around naloxone on inpatient. So it was brought as kind of a development for a good QI project. And there was 2 leads on the QI project, so my colleague Lucy and myself, who kind of initiated the project, and we then went on to do our QI training. So I suppose it was quite a big project when we look at kind of back at it. So I think there was 2 issues we were trying to address. So we were trying to look at kind of the screening for admissions for substance use, so looking at kind of how wards routinely drug screen for substance use, or if they do routinely drug screen, and then look at the kind of issuing of naloxone and the education and training around ward staff and patients. So we used kind of the model for improvement to help, I suppose, narrow down. We had quite a wide topic that could have gone in a multitude of ways. So I think using the model for improvement, we were able to really kind of look at what we were trying to achieve from the project, and then that gave us kind of our change ideas, and we were able to kind of move that forward then, and I suppose narrow down some of them aims to kind of particular kind of topics. So it helped us kind of scale down the project almost, so that we were able to kind of measure any of the change ideas. Were we achieving the aim that the project set out for as well? So the first one we did was the screening process. So we did a couple of kind of change ideas for this one. So initially we started off with how we'd kind of screen for naloxone. And initially we had a process set up where this was done through urine drug screens on the ward. But that kind of developed on because it relied quite heavily on one person. So then one of the change ideas was having kind of a specific drug screening tool around the naloxone. So that was kind of one of the first PDSAs that we planned. And then the other kind of another PDSA that we used was around the training for staff. So looking at how we'd provide training to staff, what they would look like, kind of what that would mean. Could staff then deliver the training to patients? So there are a couple of things that we kind of looked at during the project. So for us it was really important. So as a project team, so there was obviously Lucy and myself and our manager from Compass, and then we had Shelley, who was our QI lead, and the ward input. So we kind of regularly met every 4 to 6 weeks. And that would just kind of keep us all in the loop in terms of what was going on with the project, what was working well, kind of reviewing them PDSAs and looking at the action points from the previous meeting. So it was kind of that feedback was really kind of vital for us to plan our next steps in the project. So initially the kind of project was started pre-COVID, so the drug screening process on Ward 1 was already in place pre-COVID. However, when the pandemic hit, the project was impacted by that due to kind of restrictions of working from home, or kind of bubbles, so staff not being allowed on kind of certain wards due to kind of COVID outbreaks. obviously the low staffing levels and service needs. So obviously there were bigger needs at that point, obviously, that staff were required for than the QI project. So this kind of led to some of the PDSAs being delayed, and obviously the staffing issues impacted kind of particularly the ward's capacity to respond to some of the action points, due to obviously low staffing levels or kind of a COVID outbreak. So it probably added some delays to the project. One of the outcomes obviously was that we did have insufficient data, so we wasn't able to do a kind of quantitative analysis of the data, because there simply just wasn't enough of it, of the data. So, but what we were able to kind of find is that the urine drug screen wasn't an effective way of screening. It doesn't capture that any kind of historical use or occasional drug use, and also kind of relied quite heavily on one person checking that these were being done. There was issues around kind of where the data would be kept. So though we did an naloxone screening tool as well, the issue of where it would be kept, so i.e. could it be uploaded to Rio, could Rio be utilised for that, and then obviously it was quite heavily relied on the screening tool being utilised by staff on the ward, as well. Some of the other kind of findings we found from it was mainly around capacity issues, so both the Compass team and Ward 1 not having the capacity to try the cycles, the PDSA change idea. So both of us struggled with the capacity to be able to utilise them, which may or may not have affected the data. Also quite a large turnover of staff on the ward, so it meant those that were naloxone trained as well obviously left, and then it was retraining new staff members. Some of the other things to consider were about kind of weekend discharges, as well, around actually the prescribing of the naloxone and EPMA. So there's quite a few, like I said, different areas that kind of from the findings would maybe need more work or more kind of development in them areas. Like the outcomes that we got, there was nothing that surprised us, in the sense of we kind of predicted them outcomes. We knew that COVID would probably have had an impact on staffing levels. We knew that kind of how naloxone was being dispensed or prescribed would be an issue, because it doesn't go on repeat medications, and then once it's delivered from pharmacy, where's it stored, and staff remembering to issue it on discharge from the ward. And so it relied quite a lot on several different people throughout that kind of chain for it to work seamlessly. And obviously we could have it really good on one ward, but if we were to distribute this out across the whole trust, not every ward works to the same kind of level and processes. So we had to think about that and consider that. So the project's come to an end now. So it was agreed back in October that the project would come to an end, that we wasn't kind of going to benefit from prolonging the project or continuing with it. The data that we'd collected was quite minimal, but we probably that's something that we suspected would be in the first place. But I think we've learned quite a lot from the project. I think it's been a good learning experience, and also helpful to kind of present the data that we found to say, actually, if we were to consider this, there's lots of other things that need to be considered and put in place before it would work effectively. So there's we've come up with a few recommendations that obviously we're going to share within kind of steering groups and clinical governments. But I think next time, if we were to look at a QI project, it would probably be a more kind of simplified project, that could maybe help with like capacity levels to kind of change, test them, change ideas and the improvements in practice, because I think that's something that we struggled with, is kind of the capacity to, utilise the change ideas that we had. When we think about other challenges, it's probably that we'd already kind of started the QI project before we did our QI training. So we almost kind of did it role reversal. And I think had we done our kind of training first, we would have been, I think, kind of more equipped to start the project off. So we kind of made a lot of work for ourselves, in the sense that because initially we probably didn't really know what we were doing, it would have been easier to have done the training first before starting the project. The input from Shelley that we've had has been invaluable. She spent a lot of time with us going through our PDSAs, going through the live QI, kind of helping us with with the data elements of it, and that's been invaluable, and also helped because it is time consuming and it takes a lot of work. But yeah, I think that's probably, in hindsight, it would have been nice to have done the QI training first and then started the project, but actually we didn't know we needed the training until we started the project. For me, I think the training was invaluable, and that going through that kind of the PDSA cycle and the really kind of model for improvement, it really gets you to focus around what are you getting out of the project, what's the purpose of the project, and also the kind of, for me, the live QI was quite nice because I'm super organised, so I quite like having somewhere where you can input everything and it's all there, rather than having bits of paper here and there, and some in some books and some in the event. Kind of everybody could access it then and input on it. I had like 3 different spreadsheets and a different kind of notepad that had all QI stuff in it. So once we got that up and running, it just made life so much easier to utilise it. Yeah, it's a great tool when you're doing a project.